Hello everyone, welcome back. This is Shanmugapriya. This lecture is on the topic Crohn's disease. So, let's get started. The contents of this lecture are definition and epidemiology, etiology, pathophysiology, clinical features, diagnosis, pathology, treatment, and complications. So, the definition. Crohn's disease is a chronic inflammatory disease characterized by transmural granulomatous inflammation affecting any part of the gut from mouth to anus, especially ileum. Epidemiology. The prevalence of this disease is of 200 cases per 100,000 population with an incidence of 6 cases per 100,000 population. It is equally prevalent in both the sex in female and male. The typical age of onset, it is having a bimodal distribution, with one peak at 15 to 35 years and another peak at 55 to 70 years. Etiology. The main cause of the disease is an immune dysregulation and dysbiosis, which promotes a chronic inflammation. The major risk factors are active and passive smoking, familial aggregation, genetic predisposition, like especially the mutation of HLA-B27 gene. Here is a brief pathophysiology of Crohn's disease. Due to antigenic stimulation, it can be microbial or dietary antigenic stimulation. There is intestinal mucosa. It affects the intestinal mucosa by activating the gut immune system, which causes a physiological inflammation. In case of susceptible host, a susceptible host can be any person who is having a genetic predisposition or he is having an environmental factor effects of environmental factors on him. In such person, there will be an uncontrolled inflammation, which will lead to extensive tissue injury, and then it lead to Crohn's disease. The clinical features. The clinical features of Crohn's disease can be divided into intestinal symptoms and extraintestinal symptoms. The intestinal symptoms are chronic diarrhea, right lower quadrant abdominal pain, malabsorption, oral apathy, perianal fistulas. Extraintestinal symptoms. In joints, there are enteropathic arthritis. In eyes, there is uveitis and iritis. In bile ducts, there is cholelithiasis. In urogenital system, there is urolithiasis. In skin, there is erythema nodosum, and there is also pyoderma gangrenosum in the skin. Here is a picture with condensation of all the symptoms. So, the diagnosis. First, we will go for a laboratory diagnosis, which includes a blood test with complete CBC. We can see anemia sign, and we can also see an increased rise in inflammatory markers like CRP, ESR, thrombocytes, and leukocytes. So in stool, we have to go for stool culture and microscopy to exclude other infectious diseases. And then we can also detect a fecal Cal protein and fecal lactoferrin protein associated with neutrophils that can be used as a diagnostic tool in inflammatory bowel disease. We can also go for a fecal occult blood test. The main diagnosis in Crohn's disease is the imaging. In plain X-ray, we see bowel distension or a pneumoperitoneum. In ultrasound findings, we can see gastrointestinal wall thickening caused by inflammation and edema. Possible detection of fistulas and abscess can also be seen. MR enterography, it is a non-invasive, highly sensitive and specific imaging technique used to assess the extent and pattern of intestinal inflammation and edematous thickening. The main gold standard for diagnosis of Crohn's disease is endoscopy. This is both a diagnostic as well as a therapeutic tool. We do a ileocolonoscopy, which is an endoscopic technique of examining the rectum, colon, and the terminal ileum. The macroscopic findings which are found on ileocolonoscopy are segmental, discontinuous pattern of involvement, snail, snail trails, longitudinal ulceration, which can be seen in this picture, pinpoint lesions, small apathous hemorrhagic mucosal defects, cobblestone sign. inflamed sections followed by deep ulcerations that resemble cobblestone, erythema, and transmural inflammation. Then we do a esophagogastroduodenoscopy to evaluate the esophagus, stomach, and the duodenum. The findings are apathy and all mucosa. For examining the small intestine, we do a video capsule endoscopy. Here is a picture of esophagogastroduodenoscopy with snail trail appearance, and here below is a picture of cobblestone appearance. The pathology. When we go for a biopsy, what can we see? The skin lesion, there are skip lesions, a pattern of patchy, discontinuous inflammation in the bowel. There can be creeping fat, hypertrophic lymph nodes, and transmural inflammation. And we can also see non-satiating granulomas, giant cells, distinct lymphoid aggregates of the lamina propria. In this picture, in the first picture is a transmural inflammation. We can see the infiltrating neutrophils and can be seen in the crypts in the image. And below is the epithelioid cell granuloma and inflammation penetrating from the colonic mucosa to the submucosal adipose tissue. We can see the difference in the light and darkened region. The treatment. The approach for Crohn's disease includes first, we need to treat the acute disease. Second, we have to induce a clinical remission. And third, we have to maintain the remission. So, we can start with a lifestyle modification, smoking cessation, avoiding certain drugs like non steroidal anti inflammatory drugs, and minimizing stress. So, here is an algorithm for the treatment. In case of an acute episode of Crohn's disease, if there is severe complications like abscess, perforation, or toxic megacolon, we go for a surgery. If the acute episode of Crohn's disease is mild to moderate, then we start with topical steroids like budesonide or an oral 5-ASA drugs. If there is no response, we can either replace or we can combine it with antibiotics like metronidazole or ciprofloxacin. Still, there is no response. Then we classify the disease as moderate to severe disease. So we start with systemic corticosteroids like prednisone or topical steroid. In some cases, if not used before, and if there is also no response, we can either replace it or we can combine it with immune suppressants like TNF alpha antibodies or methotrexate. Possibly, we can also combine it with azithromycin. And after we treat the acute disease, we have to maintain the remission. After achieving the remission, we have to also maintain the remission. So, in the time of maintaining the remission, we can go for 5-ASA drugs. Usually, Crohn's disease leads to a lot of complications like colorectal cancer in the long run, short bowel syndrome after surgeries for fistulas and abscess, stenosis and strictures will lead to bowel obstruction, intestinal perforation can lead to peritonitis, which is an emergency, primary sclerosing cholangitis, impaired bile acid reabsorption, abscess formation, and phlegmons. That's it for today's lecture, guys. Thank you all for watching. Please do like, share, and subscribe to my channel. I will make more medical related videos. Have a wonderful day.